Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam.
Sorry, I just got the link a while from Farah. No one of you sent it to me also. Okay, we can start by Al-Kitab. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم today is group 1, yes, presentation.
Yes.
So the other group attending can يعني decrease their chair so we can give you the chance to do your job today, okay? But welcome anytime. Who is the first group?
I am the first group.
Okay, Amira and Abdullah Arif. Okay, let us go.
Right.
15 minutes for every activity. For history, for diagnosis, for differential diagnosis, and for OSCE. Okay. Everyone need to switch off the microphone during their presentation, please.
Can we start, Rata? Can you hear me?
Very clear.
Okay. Okay. Assalamualaikum, madam. My name is Abdullah Arif, final year medical student at IUM. Today, I would like to ask your permission to ask a little bit regarding your son problem. So, can I know your name first, madam?
My name is Lily. Lily.
Can pardon?
My name is Lily. Lily.
Well, can I call you Madam Lily?
Yeah.
Okay. So, what happened to your child today? Can you tell me why you come to the hospital?
I am worried because my child is breathing rapidly last night.
Oh, can I know your son name?
My son's name is Arik.
Arik, okay. So Arik has rapid breathing, eh? Can you explain more about that?
Like, it was suddenly happening last night. Like, before this, like 4 days ago, he has cough and runny nose.
Okay.
Nose okay, and suddenly he developed with rapid breathing like last night.
Okay.
And then I brought him to the clinic.
Oh, you brought him to the clinic?
Yes.
Okay. So then the clinic refer him to this hospital, like that?
Yes.
Okay. So I want to ask more regarding the rapid breathing. Did you notice during the rapid breathing any bluish discoloration around the lips? Any? No.
No.
Okay. So other than that, did you hear any sound from the breathing?
Noisy breathing, yes.
You saw noisy breathing lah.
Noisy breathing.
Okay, noisy breathing. Okay. Other than that, Razi also has runny nose and cough, eh? Okay. So runny nose, there is discharge. Can you explain more the discharge about the color of the discharge?
The discharge is green.
Green color. Green color. Okay. Next about the cough, it is with sputum or not with sputum?
With sputum.
With sputum. Color of the sputum?
It's also greenish.
Also greenish, eh? Greenish. How about the quantity? cup, lot of just small amount of the sputum?
Like small, minimal.
Minimal. It occur throughout of the day or more in the night or during morning?
More in the night.
More in the night, eh? Madam Lily, Razik had fever or not?
No fever.
No fever at all, eh?
No documented temperature.
Okay. So, I would like to ask, is there any family members who got sick, or I believe Razik already go to kindergarten, or is there any friend there who got sick?
Yes, actually, the teacher said that some of the students have fever, runny nose, like symptoms at school.
School, eh? Okay. Because currently we are in the COVID-19 pandemic, so I would like to ask, is there any history from the Sabah or red zone area or contact with COVID-19 person?
No.
No, not at all. Okay. So currently, did you notice any difficulty in feeding, poor appetite?
Yes, he have poor appetite. Usually 3 days, 3 meals per day, but today, like 2 days ago, he only had.
Okay. So there is feeding poor oral intake like that. I just like to ask you, is there Razik diagnosed with any disease such as asthma or heart problem?
Yes. Actually, Arik has asthma, like just diagnosed with asthma.
When, madam? When diagnosed with asthma?
6 months ago. 6 months ago.
6 months ago.
And then we got the inhaler. Like 2 inhaler, the blue color and also the orange color. So I use the inhaler like told the doctor.
Okay. So Arik was diagnosed with asthma 6 months ago. Okay. How about did you notice for the past 1 month any symptom during day or night that make him waking up? Is there any symptom did you notice in the past 1 month?
No symptom.
No symptom. How about his daily activity during the past 1 month? He can play around with his friend. No limitation in the activity, right?
No limitation.
No limitation. Okay. So other than that, I would like to ask: is there any? Do you find Azik loss of consciousness, seizures? Is there any episode of that?
No.
No. Any palpitation, chest pain? Did he complain chest pain? No. Okay. Any abdominal pain, diarrhea?
No.
Difficulty in pass urine?
No.
No. Okay. Okay. So I would like to ask about his medical history. Other than asthma, is there any other illness happen to Azik? Arik, I'm sorry.
Arik, no, not ada illness.
No other illness. Is there any history of hospitalization due to asthma before?
No.
No, this is the first time. Okay. Any surgical already done to him?
No.
No. Okay. So he was given medication for his asthma. Is there any allergy to medication or food? Did you notice?
There's no allergy.
No allergy, right? Okay. So next about vaccination. Arif got vaccination according to the schedule by hospital?
Yes, he did not
Yes.
miss me. Yeah.
Oh, okay, good. So, madam, I would like to ask regarding birth history of Arif. Okay, do you experience any antenatal problem?
Yes, I have low
Low
hemoglobin.
hemoglobin. Other than that? No, right? No, okay. So only low hemoglobin, eh? Okay. How about during delivery?
No, no
No
problem.
problem.
He's delivered normally.
Normally, spontaneous vagina delivery. Okay.
Yes. Normal, yeah.
At what week?
Term.
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 So no difficulty during labor.
No.
Okay. How about post delivery? Did Arik need to go to the ward, admitted, or anything else?
No admission, but jaundice.
Jaundice. For how many days? What?
Few days only.
Few days only. And then after that, it's normal lah.
Yeah.
Yeah. Okay. Madam Lily, Arik already go to the kindergarten, right?
Yes.
Okay. So, as mother, did you notice any difficulty of him during to adapt in the kindergarten?
No. According to the teacher, he has many friends and he plays with them.
So socially, he can mingle with his friend?
Yes.
Okay. Can he play like kicking ball or something? Can?
Yes. He can play sports.
Okay. Can he wearing t-shirt by himself, such as button the shirt?
Yes. I don't need to help him. He can do it himself.
Okay. How about when he talk? Can he talk in sentence or ada pelat-pelat ke?
No, he can tell stories.
Oh, he can tell stories. Okay. So I think the developmental is really okay. Okay. So next, I would like to ask about his feeding history lah. Can you explain more about how many meal he eat per day? Can you tell me?
He usually eat 3 meals per day, breakfast, lunch, and dinner. And I gave him like a balanced diet, chicken, fish, and rice. So he's not a picky eater. Like he can eat vegetable.
Good. Because not many children like to eat vegetables. So if Arik like to eat vegetables, it's really good.
Yeah.
Okay, yes, it's really good. Okay. So next, I would like to ask about your family. Can Arik, can you tell me Arik father's age?
For this age is 34.
34?
Yes.
Okay. And how about you, Madam Lily?
I'm 34.
34 also. Both of you have any disease such as diabetes mellitus?
No. My husband has asthma.
Oh, your husband has asthma.
He has asthma, rhinitis.
Any eczema or dermatitis? Skin problem?
My husband doesn't have, but Arik has eczema.
Oh, Arik has eczema. Okay. Arik has other sibling?
The sibling, yes. Yes, I have 3 children. Like Ari is the second,
Okay.
and my first children is 8 years old, and the last is 2 years old.
2 years old, huh? Both boy, girls?
Both all boys.
All boys. Okay, all boys. Did them have any problem? Asthma also like Arik?
Only Ari. Only Ari.
Only Arik. Other siblings are healthy.
Other sibling as eczema.
Eczema only. So Arik had both, which is asthma and eczema. The other 2 siblings had eczema only. Okay. Is there any history of malignancy running in your family?
No.
No. Okay. Really, can I know you and your husband work as?
Government club.
Both of you?
Yes. Actually, yes.
Okay. So can I know your a little bit educational level? Can I know?
SPM.
SPM. Both, yeah, madam?
Yes.
Okay. Okay. So how about your current household income for both of you?
The total.
Yes, total.
2,500.
I'm sorry, can you repeat again, madam?
2,500.
Okay, 2,500. Okay. So where do you live, madam?
I live in Batu 11. Batu 11.
Okay. So at your own house or you rent the house, semi-D or?
I rent the house.
Okay. So the house fully accomplished with water, electrical supply. Okay.
Yeah.
Can I know the nearest KK with your house?
KK. Nearest KK. Kuala Kuantan.
Okay.
About 5 minutes away.
I'm sorry, madam. I just want to ask regarding, do you, both of you, which is you and your husband, smoking?
My husband smoke, but outside the house.
Outside the house. Is he heavy smoking? How many? Do you know how many cigarettes per day?
I think about half box per day. Heavy smoker.
So currently, all of your children live with you, right?
Yes.
Okay. Right. So I think, in my opinion, so your son maybe got exacerbation of the asthma, most probably due to exposure from his friend in the school. Hello. Okay. So is there anything that maybe you become concerned and you want to know about this? You want to ask me? Is there any concern you want to ask?
Okay.
I'm sorry, I cannot hear you. Okay. I think
it's not.
Okay, I'm sorry. Okay, so I think that's all from me. So can we go back to that's all the history taking, doctor. So we need to proceed to?
Make summary for me. As you know, you are year 5 now. Within short time, you're working in crowded words like that, and you need to know how to do a summary, which is small but conclusive, giving all information. So just do summary and tell me your diagnosis and how can you investigate that. I will give you 10 minutes to speak.
Okay. So my patient, Ari, 5 years old Malay boy with underlying asthma, diagnosed 6 months ago. Good control of asthma, presented to this hospital with history of rapid breathing for the past 1 day, associated with runny nose and cough. There is history of sick contact with his friend in the school, and strong family history of asthma. So my professional diagnosis for this patient is acute exacerbation bronchial asthma, secondary with upper respiratory tract infection.
Continue.
Continue to physical examination, doctor.
I give you 10 minutes to finish your physical examination and the investigations and the treatments. Can you hear me?
Yes.
Okay.
Yes, doctor.
Continue, please.
Okay, wait for a minute. I'm sorry, I have mic problem. Okay, so for the physical examination performed on the second day of admission in the ward, Arik was conscious and alert. There was granular attached on the dorsum of his right hand with no active infusion. There was no sputum pot or meter dose inhaler seen around the back. He was pink and not cyanose. Also not in respiratory distress, as there was no nasal flaring, grunting, usage of accessory muscles, or any intercostalization, subcostalization, or cyanosis noted. On peripheral examination, there was no clubbing, peripheral cyanotic or tremors seen, capillary refill time less than 2 seconds, no eczema on the flexor noted. However, there was a BCG scar. On the head examination, no conjunctiva pili or scleral jaundice noted. No rhinorrhea seen. And then the hydration status was good. No central cyanosis or enlarged tonsil seen. Lymph node was not palpable. For Arik vital signs, his BP is 107 over 52 millimeter mercury, which is normotensive blood pressure. The heart rate is 100 and 110 beat per minute, good volume and rhythm, a little bit tachycardic. I'm sorry. Respiratory rate 28 breath per minute, SpO2 99% under room air, a little bit tachypnic, temperature 37 degrees Celsius, normal. His weight is 14.9 kilogram and height 105 centimeter, head circumference 48 centimeter. So I proceed to the respiratory examination. On examination, there was no tracheal deviation. The chest moved with respiration symmetrically. No chest wall deformities, scars, or intercostal and subcostal recession seen. There was good chest expansion equal bilaterally. Tactile vocal parameters was equal bilaterally, and resonance was noted on percussion. On auscultation, there was good air entry, equal bilaterally with no added sound heard. On other examination, was not remarkable. So for this patient, the provisional diagnosis, like I said before, is acute exacerbation of asthma, secondary to upper respiratory tract infection. Okay, so for my differential diagnosis, first, pneumonia. Next, maybe bronchiolitis. Next, maybe due to foreign body inspiration. Next, because currently we are in the pandemic of COVID-19, so COVID-19 must be one of the differential diagnosis. Okay. So the management, the investigation for I would like to do for this patient, if can, I would like to perform peak expiratory flow rate test, pre-net and post-net, and then after that, I would like to do full blood count to check for any leukocytosis that maybe suggest about infection. And then I would like to do blood culture and sensitivity to know the organism. If the full blood count indicate bacterial infection, if it is viral infection, we can skip blood culture and sensitivity. Okay. And then if the bleeding become more severe, I would like to perform arterial blood gas. So we can know whether the patient have respiratory failure type 1 or type 2. Okay. So next, to differentiate, to roll up pneumonia, I would like to also to perform imaging examination like chest X-ray to find is there any hyperinflated lung or consolidation there. Should I continue, Doctor?
Just concentrate on your diagnosis and delete the differential diagnosis for the other. So how you confirm it is asthma now?
So first, from the history, we know that he has strong family history of asthma and already diagnosed with asthma before. So for investigation,
Did you try to ask how is the course of the asthma?
I didn't ask about the cause of asthma, but when I asked, there is strong family history of asthma, and then the mother told me that Ari already diagnosed with asthma 6 months ago.
Yes, yes, I agree for that. But you are in year 5 now. You must be
Okay.
able to say the word of bronchial asthma. Allah is not enough. Is it persistent or intermittent?
Oh, okay. I didn't ask about that, doctor. I'm
This is
sorry.
I asked you for your original diagnosis. So you must be able to define. My original
Oh, okay.
diagnosis is, and that's why you must come retrograde and ask yourself during the history.
Oh,
Is it intermittent or not? For how long? You didn't even ask here for how long you have these symptoms of asthma and where it was diagnosed and who diagnosed that. And all this will give you the details.
oh,
It is not good for any one of us, for the patient of chronic disease. He just got the title and work with it.
okay.
This asthma, this is cerebral palsy, this is congenital heart disease. It's
Mm.
completely different. This congenital heart disease, which lesion is in failure or not, this cerebral palsy, what type, what is the problem with him, what is the complication. It is not so simple like that. Okay.
Okay.
So it looks you didn't try to pick from the history how is the severity of the asthma.
Ah,
Okay. Is it
okay.
intermittent or is it persistent? If it is persistent, it is mild or moderate or severe. You know the how to say about the course of the asthma. Is it persistent or intermittent? What point do you need to know?
Uh, do we need to know about how frequent Arik got uh,
Okay.
day or night symptom, is it?
You ask. Are you asking me?
How frequent he use the reliever?
Okay. What else?
Uh, how does the asthma affect his daily activity?
Okay. So
How frequent he use the reliever? Do we need to ask about the GINA criteria, doctor? I'm sorry, I'm a little bit confused.
why confused?
Uh,
Is it
uh,
very clear in your pediatric protocol? If you open for the
okay.
bronchial asthma, it is a very comprehensive and nice book speaking to you. How do you know the course of asthma? Is it intermittent or it is persistent? How can
Oh,
I say it? Is it mild or moderate or severe course? And for the next page, you will find how can I know is it mild or moderate or severe or life-threatening attack? And this is different.
oh,
Different. We cannot mix it together because it may be you have one patient who have intermittent asthma, but when it came to him, he got a life-threatening attack and need ICU.
oh,
And another one has persistent severe asthma, but the attack usually is not so severe or like that. So you must be able to imagine the complete situation and the diagnosis. Okay, all of you need to settle this issue because most of the time when we come bronchial asthma, a lot of you are bit clumsy. Now we are in the last step. We must be able to give a comprehensive diagnosis. It means this child with this year has persistent, okay, moderate bronchial asthma and managed by, which you didn't ask even the mother. What is the medication was given? It will guide you. You know Gina, he is very good. But which step of Gina he is in now? Okay, that's why, please, during doing the history with any patient, you must put in your mind what is the suspected diagnosis. Suspected diagnosis is bronchial asthma. Then I would like to know how severe is it. So I would like to ask 1, 2, 3, 4, 5 in the history. Then I would like to come back and ask about the severity of the attack. So 1, 2, 3, 4, 5. Then I would like to ask about compliance. Is there a good compliance for this medication? You didn't ask her how she is handling MDI, how she is giving the treatment, like that. So it is not enough. It's very critical, okay, to dealing with patient of chronic disease like that. Okay, am I clear? Uh,
Yes, betul.
Also, you forget to maintain your job as a bronchial asthma and telling us that the differential diagnosis is uh, bronchiolitis. Did you use it to see bronchiolitis at this age?
I think no lah.
Why you put bronchiolitis? This is an important issue to have what they said, a formal differential diagnosis in my mind. I will go through it all. No, I must take care about my patient, how old he is, and like that. Okay. The third and important thing, did you ask about vaccination?
Yes.
Did you comment about the BCG scar?
No lah. I will comment in the physical examination.
Yes.
I asked in the history, and then the mother told me that she complete all the vaccination.
Yes. But during the examination again, because BCG is a known vaccination which can be failed in sometimes. So I must check if there the BCG scar is there or not. If it is not there, it may be failed one, which I need to go through a certain protocol to make sure the patient is vaccinated or not. He need to be repeated or not. Okay, because it may be TB. He has a chronic cough, and someone diagnosed an asthma. Just to put in mind everything. Okay, the medicine is dynamic, not static. I will put a badge of bronchial asthma and forget anything else. Especially are going to give him steroid and some medication. So it is very important to comment about the vaccination. I didn't want to make it long, but at least you must know. You must know how we must handle that one. Okay. The other thing, you ask for travel. Okay. So who can prepare for differential diagnosis now? Who is the one who will present?
Me, doctor.
Okay, sorry, he got a part of your job.
So the first differential diagnosis will be viral pneumonia. Since the patient show flu-like symptoms, runny nose, cough, and contact with a sick person, and there's no fever.
Okay. What else? Any other differential diagnosis?
I would like to suggest possible group, but however, it's least likely because patient did not have history of hoarseness of voice or barking cough, or no low grade of fever.
What is the the age of groups?
Age of group usually
What did you suspect if the patient has group? How old
6
he?
months to 6 years.
Yes. If you have group at this age, you are going to think about something very dangerous, like bacterial tracheitis, epiglottitis, like that. Okay. What else? Who can answer? Other differential diagnosis. That is the issue, which sometimes you are clumsy inside it. Sometimes the differential diagnosis mustn't be completely something else, but it is differential diagnosis inside the diagnosis. It means it may be bronchial asthma secondary to viral infection, secondary to upper respiratory, maybe secondary to pneumonia, maybe secondary to atypical pneumonia. This is the age of atypical pneumonia, which sometimes is not so clear. So if he commented that there is some crepitation or decreased air entry or inequality of both sides, you must take care, okay? Because do you know what is the atypical microbe?
Mycoplasma.
Mycoplasma for this age, but we have yeah, if baby, if it's small, we have another organism. If baby is, if the one is looks like immune deficient, we have lignoid. So we have a wide. So just to try to know the title for that. What is the treatment of this mycoplasma?
Macrolide. We give
Yes.
erythromycin.
So
How
it
much?
is
Erythromycin.
macrolide. What if if you are starting by the first line, which is amoxicillin or amoxicillin clavulanic acid for bacterial pneumonia and no response, we must suspect mycoplasma either by investigation or by clinical, and we must add ECM or other one. Okay? It is very important. So we can still say it can be acute attack of bronchial asthma secondary or exercise induced asthma. Of course, if I have suspect other diagnosis, but now I have acute exacerbation already. So it can pneumonia with the asthma, it can be viral with the asthma, it can be like that. Okay, so you must be don't be. Of course, if the patient has chronic cough, I may suspect TB. If the patient coming to me very small and I am afraid he can be shocked like that, and the mother said he shocked like that, we can suspect foreign body, but be sensitive for that. Okay. The question now is what investigation you are going to do for the asthma, Dr. Abdullah?
I would like to perform peak respiratory flow rate.
A bit side, which I used it to tell you, please take care. We have 3 or 4 categories of investigations. Okay. There is a blood or lab. We have red. We have bedside test. We have specific test. If you try to arrange your mind, so you will not forget that. For any situation, I will not speak about asthma. You may need to speak about it, like the if I am diagnosing post-streptococcal glomerulonephritis, I will do blood test for
Culture sensitivity.
okay. What else?
So for acute glomerulonephritis, for bedside, we can do urine dipstick.
Okay, urine. Okay, for
So for
back for RBCs and the castes. Okay, and the color. So this is the bedside test. For the blood test,
the blood test, I would like to do full blood count first.
okay. What else?
Next, urinalysis.
No. Don't jump between up and down. Now we are in the blood. We have
Okay.
post-streptococcal. Post-streptococcal glomerulonephritis. So what is the test you need to do now?
Oh, ASOT. Antistreptomycin.
So ASOT for post-streptococcal. What about glomerulonephritis? What will be the specific test now?
Renal Profile.
More specific? We'll do it, of course.
Complement C3, C4.
Yes. You see now? You understand the issue now. Yes, it may be routinely we will ask for blood count, we will ask for renal function, for blood urea serum electrolyte, for kidney function test, all that. But what is the specific? A specific here is the two, ASOT and the C3, C4. So I will not forget. I mean, need to do ultrasound. I mean, need to do X-ray. Okay, if there is heart failure and the patient in stress or overload of fluids. So that is the issue. You must ask yourself during investigation for any situation about the lab, about the red, about the bedside, and about the specific test. Because at the end, if you give me all investigation, but you didn't do the specific test for that disease, you are not doing the job completely. Here in bronchial asthma, we speak about peak expiratory flow rate and the response for that, okay? Remember that during COVID time, we are preferring to go for a metered dose inhaler better than inhalation nebulization, okay? Am I clear for that also? Okay, where is your OSCE now?
I'm sorry, Doctor. Wait for a moment. My friend has connection problem.
Can you all see the slides? Hello?
Yes.
Hello, yes, we can see.
Okay.
Yes.
Okay, first.
Okay. Assalamualaikum. My name is Muslihana. So I will conduct the first OSCE. So based on the picture given, so first what is the cause of the problem? Anyone can answer these questions? Maybe Amin.
Okay. The cause of this problem could be maybe by infection. Infection cause such as pneumonia, or it could be
Alright.
allergen causes such as dust or maybe smoking.
Okay. Good. So what I meant from these questions is basically the risk factor for asthma. So among the risk factor, infection, pets, any allergy to antibiotics, exercise-induced asthma. So that could be the cause of asthma. And then the second question is what is the
Come back to the previous one, please.
yes. So
Yes, this one is very important. Thank you for this collection. It can be bit, pollution, cold weather, genetic, of course, but we mean what will cause the acute attack. Exercise, induce the asthma, and you need to put the psychological issue. If the
so
patient, even if the one with asthma is laughing very loudly, he will start to cough and wheeze. And
mm,
if he is very sad, he may become depressed and also wheeze. And don't forget to the upper respiratory tract infection, which is the most irritant one. There is some voice, please. Microphone. If someone not using his microphone, you can switch it. It is very important to include here with this slide the upper respiratory tract infection and the psychological stability. Good. Just add it because we will collect it for you after that. Okay, continue.
Hannah, your mic.
sorry. Second is briefly explain on the pathophysiology of the asthma. Uh, I would like to ask Hani to explain briefly on the pathophysiology.
Okay, so for asthma, as we know, it is hypersensitivity type 1 reaction, and there's also airway inflammation. Um, and when there's airway inflammation, and if patient have recurrent exposure to trigger, and then it will proceed to chronic inflammation, and also it can also cause tissue remodeling to the patient. Hannah, mine.
Okay. Sorry. Yes. So true that that will be what will happen on the patient if the patients continuously exposed to the substance that can inflame, that can cause irritations to the airway, causing the body to have frequent activations of hypersensitivity type 1 reaction, and then causing edematous airway, and then edematous airway, and cause hyper responsive reactions. So that can cause further tissue remodeling on that patient. Next is um, next is the this picture basically explain what the pathophysiology is. Then the third questions is the third question is um, uh, the third questions is how basically how the patient would present the symptoms of asthma. So can we have Safia?
Yes. So since you all know, it's caused by hypersensitivity reaction. So there will be a lot of production of mucus, and the bronchus also will be narrowing. So patients will present with wheezing. due to the narrowing passage, and the production of mucus will cause patient to present with coughing and shortness of breath, like tightness of the chest.
Yes, so basically for asthma, there is 4 symptoms that should be included in wheezing, coughing, chest tightness, and shortness of breath. This is the 4 main symptoms for asthma. That's all from me.
Okay, next will be me. Okay, I am Faiz. Okay, but the first question is about the tachypnic breathing rate. So it differs according to age. So I would like to ask Afika, what is the abnormal breathing rate for child under 2 months old?
For child of less than 2 months old, the tachypnic breathing rate is more than 60 breaths per minute.
Okay, we proceed to the next question. Okay, I will ask somebody else and we'll look at the answer later. Okay, for 2 months to 1 year old, I would like to ask Hani, what is the abnormal breathing rate for 2 months old to 1 year old?
More than 50.
Okay, next, for the last one, for 1 year old to 5 years old, I would like to ask Amira, what is the tachypnic breathing rate for 1 to 5 years old?
More than 40.
More than, sorry?
40.
Okay. So yes, the answer are all correct. In less than 2 months old, the breathing rate is 60 breath per minute. For 2 months to 1 year old is 50. For 1 to 5 years is 40. So we remember 654.
Is it from the last edition of pediatric protocol?
Yes, this is from pediatric protocol.
The fourth edition.
Or the third edition.
Why? Why we have the latest edition and we are still insisted to use the old one? You know that medicine is evolving. Maybe every 5 years you will find a considerable percentages of our work are changing. Okay, please, even if you are going to write up for me or like that, you mustn't use old edition. You must be Nelson 1983. In spite we have Nelson 2020. Yes, we can use it if this is a basic science which is not changeable, but it is not good. Okay, so please change this according to the other and put the full children, because we have children now from 6 to 12 and like that, and the adults, so we know the difference between different ages. Okay, okay, go ahead.
Okay. Okay. So based on this picture, I would like to ask. Amin, what is the condition?
The condition could be Harrison-Sarkai.
Okay. And give 2 differential diagnoses for the condition.
It could be one is to the chronic asthma, or maybe due to recap could be.
Okay. Yes, true. This is Harrison sulcus, which is a horizontal groove at the costal insertion, at the diaphragm insertion to the costal bone. And the diagnosis is chronic asthma and rickets. Okay. The next question is, 5-year-old child with underlying asthma present with silent chest. What is the stage after acute asthma, I would like to ask Safia.
Hello. Okay. Stage of acute asthma. Acute exacerbation of asthma. We have three stage. Eh. We have three or four. Four. Sorry, four stage. Mild, moderate, severe, and life-threatening.
So silent chest is under which category?
Silent chest. It's under life-threatening.
Okay. What are other signs you want to look for? Give me three.
Sorry, what is the silent chest?
When the patient doesn't produce sound at all when breathing. I mean,
You mean he's apneic? Do you mean he is apneic?
oh,
It is not apnea. Usually, the patient with asthma will start to go to wheezes during the expiratory phase. So he will breathe normal while expiration will if it is severe, we will put inspiratory and expiratory. The third one, it will be the patient doesn't have wheezes, but he is searching for the air because if it is severe, narrows. So the chest looks like silent one. If you leave him for a considerable time, he will collapse. Okay, but it is not typical for. It is he has severely struggled to send some air to the lung. Okay. Okay, go ahead.
Okay. So these are the features of the asthma according to the mild, moderate, severe, and life-threatening. So the silent chest is under life-threatening, and other signs of we also can also see at the accessory muscle usage is paradoxical thoracic movement in life-threatening, and patient also can be comatose and drowsy in life-threatening.
Is it third also? Third edition also?
Sorry, doctor?
Is it from the third edition?
Yes, third edition.
Even if they are the same, you must retrieve and write it is the fourth edition, just to know that we must follow. It is since 2014 until 2020 is 6 years. Okay, so also you need to change all your references to be the updated version, please. Okay, thank you for a good job, but we must be as professional as required. Okay.
Yeah, next.
Hello, Assalamualaikum. Can anyone hear me? Hello?
Hello. Yes.
Okay, so regarding the investigations that the chest X-ray finding, how about Hazira?
Hello, can you hear me?
Yes.
Oh,
Yes.
okay, so for the chest X-ray finding, there is a presence of the hyperinflation lung, evidence of widened intercostal lip.
Yes, the answer is true, Hazira.
Hello?
Yes. Yes, the answer is true.
Hello? Sorry. Okay.
Okay, so the chest X-ray it show the hyperinflated lung, and there is a small patchy consolidation suggestive of pneumonia. So actually, that is the chest X-ray of a child in severe acute exacerbation of asthma secondary to pneumonia.
Can we see the X-ray again? Where is that batches? Is it bilateral or unilateral? Bilateral. So why you are telling the pneumonia? That is the issue. It is better to say mild bronchopneumonia. Mild bronchopneumonia. It is broncho. Yes. Because pneumonia, as we know, can be bronchopneumonia, can be lobar pneumonia, can be aspiration pneumonia, it can be even atypical pneumonia. All this can be guided from the X-ray. So try to step up in your diagnosis, one step up. Okay, it is not so severe, but we need to rule out it is a bronchopneumonia. Okay.
All right. Okay, next. Next page. Okay, now I think this is already asked by Faiz just now, but we can recap. So can anyone list the parameter to assess the severity of the asthma exacerbation? There is 9 parameters that they use to classify the asthma according to the severity of exacerbation. How about Afika?
Okay, for the first parameter is the condition breathlessness condition, in which whether the patient is breathless when walking or at rest or during feeding. And the second parameter uh, is the patient able to talk in sentences or phrases, or even unable to speak. And the third parameters is the patient's alertness, whether he's agitated, or maybe agitated or usually agitated, or in life-threatening condition, patient might be drowsy or in coma. And the fourth parameters is the respiratory rate, whether it's normal or increase or markedly increase. And the life-threatening one is the poor respiratory effort. For the fifth parameters, the usage of accessory muscle, whether it's absent or moderately used, or in life-threatening condition, it will have paradoxical thoracoabdominal movement. And then the sixth parameter is the presence of wheezing, whether it's moderate, loud, more loud, or silent chest. The seventh one is the pulse oximetry, the SpO2 level, whether more than 95%, less than 92 to 95%, less than 92%, and cyanosis. And then the eighth one is the pulse rate of the patient, whether it's less than 100, 100 to 120, more than 120, or bradycardia. And the last parameter is the peak expiratory flow rate of the patient, whether it's 80% or more than 80%, 60 to 80%, and less than 60%, or in life-threatening condition, we are we are unable to perform the PFR.
Okay, thank you, Afika. The answer is true.
Which edition also?
That one is for fourth edition pediatric protocols.
Okay, but I think we need to consider two important things: ability to talk and eat. If the patient is unable to talk, sometimes you ask, what is your full name? He will say, my name is, and then for the third, it is very dangerous. Also, if you ask him or offer him a food, he said, no, I cannot. I'm so distressed now. Is a bedside signs which make you alert to assess all the others. But it is very important and consider one of the severity. Okay, thank you. Next.
Okay, hello. Can you hear me? Sorry.
Yes.
Lama.
Yeah.
Okay. Okay, so actually this is two type of inhaler. Actually I want you to differentiate. But the the box okay. It's not ni. Okay, so can anyone give explanation about difference between these two inhaler? Can I have Arif?
So I think on
Hello?
the right one, Buddhisonat, I think. Can you hear me? Hello?
Yes.
Okay. So
Okay. Yes, yes, the blue and yes.
yeah, the brown one, in my opinion, is the controller, which is corticosteroid, and then the blue one, the reliever, beta agonist, like salbutamol, I think.
Okay, thank you. Arif, that's right. So, okay. Can you show the okay, so okay, the blue one is reliever. Example can be salbutamol. Most common we call as a Ventolin. Okay, and the brown one is, can you show it, Faiz? The brown one is preventer. Okay, preventer. So example is corticosteroid. So both have different function. For the reliever, the function is it cause the relaxing muscle in the lung. So it cause the airway to open. But for the preventer, it help to reduce the inflammations. Then it keep the airway to open. Okay, next slide.
Thank you for this nice slide. Wait. This is, I will be very
Next
happy.
slide.
Can you hear me? Come back, please.
Yes, doctor.
Yes, doctor.
Yes,
I will
doctor.
be very happy if you asked what is the treatment of asthma. What you will say? Is there any curative treatment for asthma?
No, more
Curative
to
treatment.
preventive.
Is there any clever doctor who can you go to him and he will write you for medication and tell you you will not get asthma again? No.
No.
But we have, yes, but we have two wings now. You must know that. We have the reliever and we have the preventive medication. And the preventive, we must know it because this is our goal, to prevent the asthma. Instead of the patient came every day to us, we can just give him and he will live normally. He can work, he can be a student, he can do his social life. So you are going to say there is a reliever, either it is short acting beta agonist or long acting beta agonist. And we have now a lot of preventer, which is low dose corticosteroid or high dose corticosteroid. What else?
The preventer is Montelukast.
Monteliocast, which is
Leukotriene inhibitors.
leukotriene and leukotriene.
Try
Yeah, anti-leukotriene or leukotriene inhibitors. What else? Sometimes you may need to use oral steroid. It is written in the GINA, okay? And even we have IgE, which is a very expensive, but it can be considered in the life-threatening asthma, okay? So now we are dividing. Please don't make yourself Superman, which you can do anything, and at the same time try to teach the family or the patient your disease has no curative treatment, but we have a lot to do. We can give you reliever, we can give you preventer, we have 5 steps, we can go through all that. If you are very compliant, you will find a very good result. Okay, so if you ask it for treatment, don't forget to tell that. Okay, next one.
Next slide. Okay, so this is actually the level of the control of asthma patient in China based on fourth edition PITS protocol. So it is simple. I just for the sentence, I just want you to read, and if it is true, then say true. If it's false, then say false. Can I have Amira?
Okay. So for the first one, daytime asthma symptoms more than 2 weeks in 5 years old for the past 4 weeks is false.
Next.
Okay. And the second one, limitation of activities for the past 4 weeks is true. And then reliever needed for symptoms true. Nocturnal symptom for the past 2 weeks is false.
Okay. Guys.
Yeah, for 4 weeks actually. Okay.
Okay. Okay, so the answer is true. Okay, the answer all is true. So for the daytime symptoms for the 5 years old and below, they might have more than once daytime symptoms per week, and for 6 years and above, they must have twice per week. Okay, that's all true. And then next slide. Okay, so next slide. So this is the example of the type of inhaler that we can see in hospital. So can you give me name for each type of inhaler? It's okay if this is wrong. I will show you the answer later. So can I have Faiz? Sorry, Faiz. Sorry. Hani.
Okay, so
One
for
for the
the
first one.
first one is the MDI, meter dose inhaler, and then next is the spacer, and
Next.
then at uh, at uh, the, at the bottom is spacer with mask, and then the next one is uh, dry dry, dry powder inhaler, if I'm not mistaken. Can you guys hear me?
Yes.
Yes, true.
Yes.
Yes, yes. Okay. Okay, so that's the answer. Okay. Okay, methods MDI, spacer with mask, nebulizer and compressor, dry powder inhaler and spacer. So basically that's the type of inhaler that we need to know in the hospitals. Okay, for the next slide. Okay, so basically this is the step for the correct inhaler technique. So is any one of you guys volunteer to explain about the correct step based on the picture? Anyone volunteer? Anyone know? Okay. So Faiz, can you open the answer? Okay. Okay, first we need to shake the inhaler. Okay, we need to shake the inhaler 3 to 4 times. First, second, we need to open the cap. Next. Okay, Faiz, next. We need to open the cap. Okay, remove the inhaler cap. Okay, third, we need to breathe out completely and slowly. Okay, fourth, you bring the inhaler to your mouth. You place it between your mouth and teeth and seal the lips around the mouthpiece. Okay, make sure there is no spaces. And then five, you press down the inhaler. At the same time, you press up down, you need to also breathe in slowly and continue until you have taken full breath. And the last, you remove the inhaler from your mouth and hold the breath for 10 seconds and breathe out slowly.
There is one more.
Okay.
There is one or two steps.
Okay, so that's all from me.
No,
Thank you.
listen to me, please. There is extra two steps. Okay.
Okay,
The
doctor.
most important now we are considering spacer.
Okay,
Spacer,
doctor.
we are considering it is the best even for adult now. Because whatever you are meticulous, but sometimes because the patient is very distressed, he cannot do the same technique. He is a very hurry. So we are advising now spacer. Even for adult now, they are trying to shift to spacer. So you must write now recommended using spacer may give a good results. Okay. The second one, which is most important also, after 20 minutes of using steroid specifically, you need to do mouth wash. Why?
Because
Due to metallic
Sorry?
taste, maybe due to after effect taste, like it's because right now to be.
No, it will decrease the probability of getting a fungal infection in the throat and the mouth. So usually we are asking after like 20 minutes or 30 minutes just to do mouthwash. Okay, so it will allow fungal infections because one of the side effects with repeated use of steroid, it can do like that. Usually if the patient are eating, drinking, it may clean that also, but we insist for that if the patient are susceptible. Okay, good. You just add these two points for this nice one. Okay, and also if you are going to put this one in inhaler, you need some another instruction in the spacer itself. Can I see the next one? It may be given the point. تعالي هاتي الكرسي ده جنبي تو تعالي كده انا هقفل.
Doktor terleft kan? Hello?
Doktor macam live. Macam live je.
Tunggu kejap kot, takut doktor ada line problem ke.
Dry powder inhaler macam ni aku tak pernah nampak orang pakai.
Hear me?
Apa dia?
Dry powder inhaler. Tak pernah tengok orang pakai dry powder. Biasa tengok MDI dengan ni face atau nap.
Tak pernah tengok juga sebenarnya. Tapi ada lah, memang ada. Tapi tak sure macam mana.
Oh, spacer punya steps. Tak pernah pakai pula spacer steps.
Untuk yang spacer tu, hari tu waktu saya elective saya ada belajar waktu dekat hospital Shah Alam. Pharmacist tu ajar supaya macam kan kita after yang kita dah pump benda pump dia punya medication tu into the chamber, dekat dia punya spacer tu dia ada macam something yang macam click tau. So every time kita breathe in and breathe out, benda tu akan berbunyi. So kita kena breathe in and breathe out about 10 times. So basically benda tu akan make sure all the medication kita dapat lah. Sebabnya usually kalau guna metered dose inhaler ni dia macam kadang tu macam kita bernafas terlalu laju ataupun terlalu perlahan yang menyebabkan medication tu tak efektif. So pacer ni membantu in terms of that lah. Macam tu.
Okay, thank you Hana.
Yang MDI tu rasanya pernah kat FEMAC kot pernah cakap one of extra step is before kau pump tu kau kena press sekali kan, especially kau dapat baru to make sure dia function.
Betul-betul.
Macam kau pump
Betul-betul.
outside sekali.
Betul.
Itu
Priming, yes.
itu kalau baru ataupun dah lama tak guna.
Betul. Yang apa doktor kata tadi, asma tu tak ada definitive treatment cuma dia akan resolve, dia boleh resolve on its own kan in the future macam tu.
Tak ada
Tak
curative,
faham sangat tu.
tak ada curative treatment, maksudnya dia tak boleh sembuh.
So tapi yang bila patient kita kelak kadang-kadang dia kata dia tak ada asma dah like 10 years, hilang masa teenager, yang tu macam mana pula case tu?
Entah.
Kan kalau dia tak ada,
Kalau saya rasa lah untuk patient-patient tu maybe sebab dia punya asma tu macam dah very control macam tu. So sebab tu yang macam dia dah tak perlukan reliever dah.
oh, okay. Jadi ada PRN yang apa, ada yang untuk apa? Sabutama je lah kalau dia perlu. Macam tu lah.
Betul-betul. Betul-betul.
Thank you.
Mungkin Hani boleh WhatsApp doktor ke?
Nak kita WhatsApp ke?
Kak Hazira yang WhatsApp
Kita
doktor.
WhatsApp
Boleh
Tanya-
tanya
tanya.
status.
Okay. Doktor dah left ke? Dah habis ke? Doktor left.
Belum. Aku rasa doktor terleft.
Assalamualaikum.
Waalaikumsalam.
Waalaikumsalam.
Yes, what happened? I was interrupted. I don't know. Okay, I can hear you now. You can continue, but the screen is not clear in front of me. Are you still presenting your slides, Oski?
No, we have finished the OSCE. We can move to the next case.
Okay, okay, but you need to do the correction which will guide you for that OSCE, okay? And send me what is this, the case summary and the OSCE, please, okay?
Okay,
The
Doctor.
second case is
Okay, so let's move on to the second case.
okay.
Kak Hazira, are you ready?
Yes. Can you hear me?
Okay, can you hear me? Yes, I can hear you. Alright, so Assalamualaikum, madam. How are you today?
I'm fine, thank you.
Okay, let me introduce myself first. I am Safia, a fifth year medical student. So I would like to ask a little bit about your child. Is it okay for you?
Okay. Can you hear me?
Alright, but before that, may I know your name, madam?
My name is Madam Asma.
Madam Hasma. Is it?
Yeah.
Madam Hasma. Alright. So what do you do, Madam Hasma? What is your occupation?
I work as a clerk.
Yeah, clerk. Okay. How about your husband?
I work as a clerk.
How about your husband?
My husband work as engineer.
Engineer. Alright. So okay,
He
okay.
is an
So
engineer.
about your child, is it a girl or boy? Because I cannot see from here.
Okay, my child is a boy,
It is
8
a
years
boy.
old boy.
What is his name?
Muhammad
Azim.
Azim.
Okay. So what brought him to the hospital?
So actually, my child have a swelling problem around his leg and also his face area.
Around his leg and
Face area.
face area. So the face is swollen together with the leg. Is it both of his leg?
Yeah, both of his leg.
Alright. So how long has it been, the symptoms?
It is 2 weeks ago, starting 2 weeks ago.
Starting 2 weeks ago. Alright. So it started with the facial puffing, facial swelling first, or the leg swelling?
The facial swelling first, and then
Facial swelling.
the leg, followed by the leg.
Can you describe it more, the facial swelling, whether it's worsening over the time, or probably it's prominent on which part of the face?
Yeah, it is more prominent around the orbit of the eyes area. Okay, and then actually it worsening by time lah. It's worsening by time.
It's worsening by time. Alright. So for
And
the
it
leg
is
swelling,
and
it is, sorry,
yeah,
it is what? Can you continue?
yeah, for the leg swelling. Okay, actually for the facial puffing for the facial swelling, it is exacerbated in the morning.
Oh, so it's worse at the morning.
It is worsening in the morning.
Okay. Does it resolve throughout the day?
No, it's not
It's not
resolved.
resolving. So about the leg swelling, what is the pattern of the leg swelling? Does it start from the ankle, or
Yeah, it start from the ankle and currently
it start
up
from
to
the
the
ankle
knee.
and then extending up to the knee? Right. Is the child is your child Muhammad Azim complain any pain at the swollen part?
It's not
It's not
pain.
painful. All right. So how about the color changes? Did you notice any color changes around the swollen part?
No color
No skin
changes.
color changes. All right. Okay. So the swelling is up to the knee. Does it disturb his walking? Can he walk properly?
No, it's not
No,
disturbed.
it's not disturbing. All right.
Yes,
So,
yes, he can.
okay. So leg swelling, facial puffiness. Is there any abdominal distension? Like you see the
Yeah,
right. Okay. So
yeah, yeah. The abdominal look bigger.
okay. The symptoms appear together with the leg swelling or later on the abdominal distension.
It is.
You're not
Sorry, I'm
sure.
not
It's
sure.
okay. It's okay. How about the genital part? Is there any swelling like scrotal swelling?
Yeah, I just found out that this morning, uh, there's this morning that he has a scrotal swelling also.
Okay. So did you notice that your child gaining any weight?
Yes, he gained 6 kilo in these 2 weeks.
6 kilogram in these 2 weeks.
Yes.
So do you believe it's because of the swelling or probably because of his changes in diet?
No, it's not. His diet. His diet is like normal.
Like normal, alright. Okay, so did he experience any episodes of like shortness of breath, chest pain?
No, no shortness of breath, no chest pain.
No chest pain, alright. So other than that, is there any symptoms that you would like to share? I mean, that concern you?
Okay, so my son also have complained that lately, his urines look like like look like it's like more bubble in her urines, like more bubble, and also the color is slightly darker. It's not.
The color is
It's
like.
darker.
So how long has it been? The bubble like urine?
3 weeks ago.
3 weeks ago. So the symptoms appear even before the swelling, is it?
Yeah.
Alright. So is there do you notice is there any changes like the color of the urine turns into red or tea colored urine? Like the presence
No.
of blood. Okay.
No, it's not red in color.
Alright. So how about the frequency? Is there any changes in terms of frequency, whether it's reduced or increased
No, it's not
compared to normal
reduced or
days?
it's not increased. It's
It's not reduced. How many times did he urinate per day?
3 to 4
3 to
times.
4 times. Just like the normal days, isn't it?
Yeah.
Okay. But before that, I would like to ask, did he still wearing a diapers?
Diapers? No,
No, so he's able to do everything
because he's
himself.
8 years old.
All right, good. Okay, so how
Yeah.
about the changes in volume? Did you notice any changes in volume, whether it's reducing volume or increasing volume of urine?
No, it's normal.
It's normal, all
No
right.
changes.
How about, is there any time when he feel like he was unable to hold the urge to urinate?
No.
No. How about, did you notice any dribbling when your child, especially at the end of the micturition?
No, he's not complaining that.
He's not complaining that, right? How about pain? Did he complain any pain during micturition?
It is a painless.
It's painless, so he did not complain any pain, is it? Even at the genital part?
Yeah.
Okay. How about did he usually pee during nighttime at sleep?
I'm not sure about that. Sorry.
Okay. Is there any fever?
No fever.
During the symptoms, all right. Aside from the bubble-like appearance, did you notice any like sandy appearance? Like a sandy light? Or pussy?
No.
No. Did he complain any abdominal pain, especially at the lower part of the abdomen?
No abdominal pain.
There's no abdominal pain. Sorry, is this his first time of having these symptoms?
Yes, first episode.
So this is his first time, alright. Okay. There's no blood in the urine. Did he complain any like headache or blurry of vision?
No,
No. How about prior to the symptoms? Like 2-3 weeks before the symptoms appear, did he experience any fever?
no,
No. How about skin infection or sore throat
no, it's not complaining that.
before the symptoms appeared? There's no skin infection, is it?
Yeah,
Okay. How about did he experience any skin rashes around his body or his face?
no skin rash.
No skin
No,
rashes. About the joint pain, did he ever complain of you moving up? The joint is painful?
no joint.
No joint pain. All right. So there's no bullying. How about did you notice that your child eating a lot in large amount at one time compared to normal like he did?
No, he
No.
has a normal diet.
How about
He just eat like normal.
did he drink a lot of water? Like he's being always thirsty?
No,
No. Okay. Is there any diabetes running in the family, like you yourself or your husband?
yeah, I have a diabetes mellitus.
You have a diabetes mellitus for how long already?
Since 5 years ago.
5 years ago. So you've been treated with what?
Metformin. Metformin.
Metformin. Okay. How about your husband?
My husband doesn't have any illness.
So your diabetes, do you know you have a sorry. Okay, next is did he take any medication prior to the symptoms?
No.
Is like ibuprofen, like NSAID, non-steroidal anti-inflammatory drug? No. How about antibiotics?
No.
No. All right. How about the traditional drugs or the over-the-counter drugs? Did you give any kind of drugs like that?
No.
No.
I'm not giving any drugs.
Did he has any history of allergy before to drugs or food?
No.
No, so no drug or food allergy. All right. Is he being active since the symptoms appeared? How about his daily activity?
Daily activity just same.
Just the same.
It's still active.
Okay. All right. So, did he has any underlying disease or illness?
He doesn't have any underlying disease, but during his newborn, during his delivery, during his birth, actually he has admitted into neonatal ICU due to the heart problem.
Heart problem. So it was diagnosed during birth.
During birth.
Oh, what the doctor told you about the heart problem?
The doctor told me that it was not a big issue because it was okay, the doctor doing the echo at that time, and then the doctor said that it doesn't need any intervention because it can close spontaneously, something like that.
Oh, does he experience any symptoms like shortness of breath, the lips turns into bluish?
Currently, no. It's just only during the birth.
All right. So is there any medication that he took for his heart?
No.
No. So is there any follow-up?
Yes, yes. He has regular follow-ups. It's monthly in IJN.
Oh, I see. All right. So far, there's no any, intervention, right?
Yeah, no intervention.
Okay. So is this his first hospitalization?
No, this is his third hospitalization. The first one during 2 years old due to the pneumonia, and second one during 4 year old due to the detergent injection.
Oh, detergent injection. So is there any complication of that?
No, no complication.
No. Okay. Is there any surgical procedures been done to him?
No.
No. As for the vaccination, did he vaccinate according to the schedule?
Yeah, he has a complete vaccination.
Complete vaccination. Is there any complication after vaccine, like fever or rash appeared after the...
No.
Alright. So during pregnancy, during you pregnant Muhammad Azim, do you have any disease?
Yeah, I have hypertension and also diabetes.
Hypertension and diabetes. Is it well controlled, your diabetes at that time?
Diabetes. Sorry, I only have hypertension at that
Oh,
time.
you have
11
hypertension.
years ago. Yeah.
Oh, okay. So is there any complication antenatally to the baby? When
No
you have
complications.
no complication. So your hypertension is being treated, right?
Yeah,
Okay. Do you remember your blood pressure at that time?
I cannot remember.
Okay. It's okay. So he was born normal or cesarean section?
Emergency C-section.
Emergency C-section. All right. So at how many weeks?
31 weeks.
At 31st week. All right. So he was born preterm. How about his birth weight?
1.45 kg.
1.55 gram. So postnatally, did he get admitted?
Usually, yeah, it's warded in the NICU for 60 days due to the heart
Remaining 3
problem.
minutes. Remaining 3 minutes only.
Okay. So for the growth, did you notice do your child growing properly, appropriate to his age, according to your observation? Do you think?
Yeah.
Yes. How about his
Yeah.
performance at school?
Yeah, he's good. He has a good performance at school.
Is there any learning environment?
No.
No. Okay. How about breastfeeding? You breastfeed him until what age?
Yeah, until 2 years old.
Until 2 years old. Is it exclusively breastfed?
Okay. During the birth, it's not exclusively. Okay, it is alternate breast milk because my son is in ICU, so they also give a formulated milk.
Okay, I see. So at what age he started to wean?
6 months old.
6 months old. Good. So currently he's able to tolerate orally. Is there any changes in appetite?
No, no changes.
No. So you have diabetes mellitus and hypertension, right?
Yeah.
How about your husband?
He doesn't have any illness.
So is he your only child?
No, I have another 3 child.
Is there any similar presentation for your other two children?
No, all are healthy.
All right. So where do you live?
In Felda, Felda Kemasul, Bentong.
Okay, so it's your own house, is it?
Yeah.
So it's complete with basic necessities, is it?
Yeah.
Okay. So how if I may ask, your household income per month, including your husband?
Around 4,000 plus.
4,000. Sorry if I ask, did you do you both, you and your husband smoke?
Sorry, no.
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 Okay, sorry if I ask, did you take any alcohol?
No, it doesn't
No,
have
alright.
any.
Okay, thank you. Is there anything else you want to tell me or ask me?
I think that's all.
That's all. Okay. So
Tell us what is your impression or your diagnosis.
My impression would be primary nephrotic syndrome or idiopathic nephrotic syndrome.
What else?
Sorry?
What else? Does the patient got any other diagnosis?
Oh, okay. So my differential diagnosis will be
not differential diagnosis. The patient has, as you said, primary steroid resistant,
nephrotic.
steroid, okay, sensitive nephrotic syndrome. Yes, he has also query congenital heart disease. Yes.
Sorry, I cannot hear you.
He has query congenital heart disease.
Yes, query congenital heart disease.
Okay, so how can you?
But asymptomatic.
Yes. How can you diagnose now the nephrotic syndrome?
So by doing a blood investigation, do you mean?
Clinically and investigation, both.
So, okay, first of all, I would like to do a full blood count just to assess his current condition. And then, because I want to diagnose nephrotic syndrome, so patient will have a cardinal sign, which are hypoalbuminemia. So I would like to do liver function test to look for his albumin. And since he presented with edema, so I expect the albumin will be low. And then I would like to do renal profile to assess is there any features of renal failure, which might be a complication of the nephrotic syndrome. Then one of the features is hyperlipidemia due to the compensatory mechanism. So I would like to do a lipid profile. And then I would like to do a urine full examination, microscopic examination to check for the presence of protein and if there is any blood, microscopic blood, to rule out the nephritic syndrome. And if there is a presence of protein, I would like to proceed with a 24-hour urine collection.
Any other test for protein in the urine?
Sorry?
Any other test can be done for the protein other than 24 hours?
The urine protein creatinine index.
Yes, it is a very important. What did you suspect it to be?
If it's presence of proteinuria, the urine protein creatinine index will be more than 2.
2 or 0.2?
Sorry?
0.2 or 2?
2. It's going to be 2. More than 2.
Who can tell us the normal or urine protein creatinine ratio? What is the normal for protein creatinine ratio? It is very important and the simple test and can give you ability to diagnose rapidly the case and start the treatment. Okay.
Less than 0.2 is normal. Right?
Okay. So not 2. We are not
Oh,
waiting
sorry.
to be doubled 10 times to diagnose. Okay. The other thing, what is the specific test for nephrotic syndrome? You said cholesterol and lipid profile. You said also albumin in the blood. What about the urine itself? You said we can see the albumin, we can see the protein creatinine ratio. What other important test must be done for the urine?
Urine FPME, full examination, microscopic
Okay.
examination to
To
look for
rule out from what?
to rule out the nephritic
Okay,
syndrome.
so how can we see glomerulonephritis in the urine?
When there is a presence of blood, so we can proceed with ASOT titers.
What is the specific for glomerulonephritis, not for post-streptococcal? Is the C3
or C3C4 complement level.
C4. It is very important. But the most important, what is the color of urine in glomerulonephritis?
The color is dark to red color.
Is it red? No
If it's my
no one said it is red.
It's dark color, tea-colored urine.
Yeah, you used to say it is cola or tea color, yes?
Tea color.
Why not red?
Because the hemoglobin is already oxidized, so it cannot be red. If it's red, the bleeding is coming out from outside.
Yeah, just remember that it is the same like melena and fresh bleeding from the rectum. It is the same. If it is up, it will be changed and become black. If it is down, it will be fresh blood. So if you find the fresh hematuria, it is not glomerulonephritis. Glomerulonephritis, the cells are distracted and came as hemoglobinuria. Okay. If you find the patient coming to you with fresh blood, you must think about other, either stone, either malignancy, either infection, like that. Okay. So it is very important. The urine cast, is it important?
The urine, what?
Casts.
Sorry?
Casts.
Sorry, I'm not sure, doctor.
Who can answer?
Red blood cell cast is the pathognomonic for acute nephritis.
Okay. What type of cast we can see in nephrotic?
Red blood cell cast? No.
No.
Red blood cell cast in the acute nephritis.
So you need to answer these questions. The castes in the urine. It's very important and to guide us.
For the nephrotic syndrome is fatty cast?
Yes, that is the difference. The other one is RBC's cast. Okay, it is very important also. That's why we must ask for urine for FME to rule out, because sometimes the case is nephritic, and sometimes it is a mixed picture. Sometimes we need a further investigation to come to a conclusion. Is it mixed picture of nephrotic, or it is just going to one side? Okay. Renal function test, of course, is very important because it is one of the complication. The last question for you: what is the most common complication of nephrotic?
Thromboembolic disease.
And I mean by that, you must check for it during examination of the patient. Okay, thromboembolic disease. Why?
Because there is due to the permeability of the glomerulus, there is also secretions of the clotting factors.
This will cause thromboembolic. It will cause infection. This can cause infection. This is the mechanism of infection.
Okay.
Is it because
Due to
Okay. Because of
is it because reduction in the anticoagulation and liver synthesis of overproduction of the coagulation factors?
يبقى detergent in coagulation factors. What else? Very important. One of the criteria is
coagulability.
hypercholesterolemia. Cholesterols and the other are high. The third one, there is shrinkage of the intravascular volume. The patient is edematous, yes, but the intravascular volume sometimes are very shrinked. Even the patient can be presented by shock while he is in edema. That's why to know the mechanism and the deal how you are resuscitating the child to give intravascular volume while he is edematous. Sometimes you can go for human albumin, you can starting the steroid. All this will shift the things again. Other complications than infection, hypercoagulability. What is the most common infection you can see? Shafi ولا شافية?
The commonest infection is peritonitis, spontaneous bacterial
So primary
peritonitis.
spontaneous peritonitis. It is very important. What is the organism?
It may be caused by Streptococcus pneumoniae.
Capsulated organism. Okay, it is not like the normal, which is gram negative. Very good. So we have now a lot of complication. We can add failure. We can add shock. Okay, so we have a lot of complication. And the most common one, which you mustn't forget, is what is the treatment of nephrotic syndrome?
Steroid therapy.
Right.
What is the side effect of steroid? So now Hani can tell us. Hani?
Cushingite syndrome.
Yes. So it is very important to rule out this complication. Because you are giving steroid for 1 month, 2 months, up to 6 months. If you relapse, you are giving it again. So any patient with nephrotic syndrome, you must tell us, did he got side effect of steroid or not? You must write this in your homework. What is the criteria for diagnosing Cushing from 1 to 10? Okay, it is very important. And now, I mean not theoretical knowledge only, I need the practical and the clinical points. Am I clear? Can I see the slides, because your time will be ended with me within 10 to 15 minutes. Slides.
Okay, 1 minute at a time. Find the slides. Hello, can everyone see this? Sorry. Sure. Could I have 1 minute?
Okay, Assalamualaikum warahmatullahi wabarakatuh. So I'll be asking about the etiology of nephrotic syndrome. So Muslihana, would you like to answer the question of the etiology of nephrotic syndrome? Hana? Oh, Hana.
Yes, kejap I'm sorry. Wait a minute. For the etiology. So one of the etiology is if there is any prior infections to the staphylococcus. And then
Afika, may I try?
Sure.
Okay, so etiology for nephrotic syndrome, primary and secondary classification. So for primary, mainly the idiopathic one. And then for secondary can be caused by such as post-infection just now, like Musiana has told us, and then metabolic like diabetes mellitus.
What is the most common infection?
Most common infection is schistosoma. No, not schistosoma. Wait. The most common is
Postcoccal infection.
streptococcal.
HIV, hepatitis,
Okay.
with some other infections. Okay.
Okay.
Okay, continue.
And it can be due to autoimmune disease like SLE, rheumatoid. Okay. So it can also be due to drugs like NSAID, phenytoin. And it can also be due to malignancy like lymphoma or I think that's all.
Okay, thank you, Amira and Muslihana. Okay, Amin, you can expose the answer. So basically, the etiology of nephrotic syndrome can be divided into primary and secondary, and the most common for children is the primary one, which is minimal change disease, primary focal glomerular sclerosis, membranoproliferative glomerulonephritis, and idiopathic membranous nephropathy. And the secondary causes of nephrotic syndrome, as written there, SLE, HSP, chronic infections, for example, Hep C, Hep B, HIV infection, diabetes, malignancies, and congestive heart failure, as well as constrictive pericarditis. Okay, so which one is the most? Okay, sorry. Okay, which one is the most common? Would any one of you like to answer?
Primary is the most common.
Okay, okay, that's true. Correct. Okay, I mean, okay, thank you. So the primary or idiopathic nephrotic syndrome is the commonest cause in children, as I mentioned just now. Okay, idiopathic nephrotic syndrome is defined as the apparent primary nephrotic syndrome, which is prior to renal biopsy, which means that when before you do renal biopsy, the diagnosis is idiopathic nephrotic syndrome. But once you have done the renal biopsy, then it will change to specific causes of primary nephrotic syndrome, just like I shown before in the table. Okay, next one. This is just for you to read by yourself. I'm not going to touch it. Okay. Okay, so pathophysiology. Safia, would you like to answer the pathophysiology of nephrotic syndrome?
Hello, okay. So for the pathophysiology, so it started at the glomerular, when there is a defect in alteration, the podocyte, which is act as a filtration, is defected. It may increase the glomerular permeability. That's why a lot of proteins being lost. So the patients will have a hypoalbuminemia, which is the proteins. And then this will lead to plasma oncotic pressure also in the blood will be reduced and lead to third space loss. So that's why patients presented with edema. Apa lagi? Okay, and then for the hypolipidemia is a way of mechanisms from the liver to counter the hypoalbuminemia. So the liver will produce protein at the same time will produce lipid. So that's why patients have hypolipidemia. I think that's all I can tell you.
Thank you, Safia. Okay, that's correct. Okay, so basically this is the pathophysiology. I took this one from Nelson's pediatric textbook. So it started when there's alteration of the normal glomerular cellular and basement membrane barrier, and this will lead to increase in glomerular permeability. Thus, it will impair the restricted filtration of the serum proteins. So this results in massive proteinuria and decrease in serum proteins, especially the albumins. And because of this, the plasma oncotic pressure will be reduced, just as mentioned by Safia just now. So when the plasma oncotic pressure reduced, this will cause third space loss, which is the fluid shifts from the vessels to the interstitial compartments. Thus will result in hypotension. And also, the reduction in the effective circulating blood volume leads to the edema. And this will cause increase in tubular sodium chloride reabsorption due to the RAS activation, the renin angiotensin aldosterone system activation. And also, because of the hypoproteinemia states, this will stimulate hepatic lipoprotein synthesis and reduce the metabolism of the lipoprotein, thus results in elevation of the serum lipids. So patient will be presented with hyperlipidemia. Okay, thank you, Safia. Yeah, I think that's all for me.
So, inshallah, we will continue to the clinical signs of nephrotic syndrome. So, I took this all reference from the two books. Okay. So, can someone guess what is this? Anyone want to suggest? I want to give the answer for this. I think it is easy.
Periorbital.
It is.
Preorbital edema.
Yes, this is periorbital edema. So one of the clinical sign of nephrotic syndrome is periorbital edema. Like our patient also have periorbital edema. So periorbital edema occasionally notice when in the morning from when patient waking up from sleep. Okay, so this patient, as you can see, this during the periorbital edema. Next, this after the remission. Okay, so next. Okay, can you guess what is that? Anyone? On the
Edema.
on the leg? Okay.
Leg edema.
Yes, correct. So there is scrotal edema and leg edema. So according to Escape, 95% patient with nephrotic syndrome presented with edema. So it first appears in the area of low tissue resistance, such as in the periorbital, scrotal, and then the leg. So that's why these three parts occasionally happen first, other than other part. However, if the edema become more progressive, it can be generalized edema and then lead to anasarca, massive edema of the whole body. Okay. Next.
Like, what is this massive edema? Yeah. Okay. Continue.
Continue. So this one, as we can see, this is the abdomen is distended, which is we call it ascites. Next, ascites. So this one is ascites. Also one of the features of nephrotic syndrome. So from the pathophysiology, we know that there is third space loss of fluid. So the third space loss of fluid will cause all the edema. So if there is progressive or worsening, it may affect the children to get breathlessness. So when so one of the complication of this is breathlessness. So patient can present it to the hospital also with breathlessness as the complication of all the third fluid, all the third space loss of the fluid. Okay. So next. So this is
Sorry,
the okay.
I mean, can you comment in this picture, please? You said there is huge distended abdomen. What else?
So this basically distended abdomen is due to fluid accumulation in the abdomen, what
Other
we call
signs,
ascites.
other signs in front of you. What is this? You must comment clinically for that. Is it what is for the umbilicus?
The umbilicus is pointing outward.
Yeah. So is it everted umbilicus?
Inverted. Sorry, inverted.
Everted, not inverted. What about any blood vessels you can see? You must comment by clinically. And if you are speaking about picture alone, we know that it can be 5F, yes? If you see any distended abdomen, it can be fat, it can be fluid, it can be fetus, it can be flatus, it can be, if you come to your pathophysiology. In this situation, yes, it will be ascites. So you need to confirm ascites by 2 tests.
By physical examination, doctor?
Yes, yes.
So shifting dullness
And
Fluid,
ah,
fluid trail.
transmitted thrill. Okay. Continue.
so this is a summary of the clinical signs of nephrotic syndrome. As I would like to add about infection. So some of the patient with nephrotic syndrome tend to get infection because of loss of immunoglobulin during the proteinuria. So they tend to get infection such as peritonitis, septic arthritis, or sepsis. In the literature, they said that some patient they have peritonitis. However, the doctor cannot elicit the signs, the other signs, and then mistakenly do the suspect of appendicitis. So please be careful with children who complain of swelling and abdominal pain because maybe it is peritonitis, not appendicitis. Okay. Then
yes, I mean for the breathlessness, it is very important, please, in every patient with severe edema.
Yes.
You must percuss the cyst and make sure that he doesn't got pleural effusion. Okay, or even sometimes the heart failure, you can feel the pulmonary edema signs. Okay.
Okay, and then the last one, the patient may present with foamy urine. Like in our case, the patient also have complaint bubble in the urine. So bubble or foamy urine may indicate proteinuria. So we need to further investigation about that to confirm the proteinuria. Okay. Overall, all of this can make patient irritable and malaise. So that's one clinical sign of nephrotic syndrome also. I think that's all about the clinical signs.
Okay, now let's move to the investigation. So for the investigation, most of it has been nanti jap. Most of it has been explained by Safia. So can I have someone to list the investigation? Maybe we can have Fitri.
For the investigation that can be done, a protein creatinine index of more than 2, and then 24-hour urine protein, and then liver profile to look for hypoalbuminemia less than 25 gram per liter, and then a full blood count for low hematocrit.
Okay. Okay, thank you. Okay, so okay, next. Okay, so I will go this quickly. I have divided into lab, blood, imaging, and also a specific test. So for the urinalysis, in nephrotic syndrome cases, usually there will be 3 plus or 4 plus proteinuria and 20% of microscopic hematuria. And then next is urine protein creatinine index, which has been mentioned by doctor, important. More than 2 indicates nephrotic range proteinuria. Next is 24-hour urine collection.
Is it more than 2 or more than 0.02? 0.2.
0.2. So, because normal is less than 0.2.
Okay, so why you put 2 again? You must correct that.
Okay.
Both of you said 2, in spite we said the normal is less than 1.
Because in the Nelson, it's put 2. It's more than 2.
Which edition?
Oh my god. Okay.
We have now Nelson edition is 21 edition. 21 edition. It is available if you need to drop it to you. Also for the illustrated, I send you to the group now the latest edition also.
Okay.
Okay.
Thank you, doctor. I will correct it later. And then next is 24-hour urine collection. More than 40 milligram per meter square per hour indicates nephrotic range proteinuria. And then full blood count. This is to assess the patient baseline of patient condition. However, they can have increased hematocrit from hemoconcentration and also from intravascular volume depletion. Okay, next. Okay, and then renal profile to assess the complication of nephrotic syndrome such as renal failure. And then liver function test, as we know, to assess hypoalbuminemia less than 2.5 gram per deciliter. And if the nephrotic syndrome is a secondary causes such as in the hepatitis B and C infection, we can see there is increase in the AST and also ALT. For the lipid profile, we can check for hyperlipidemia, increase of cholesterol, triglyceride, LDL, and also VLD. And there will be normal or low HDL. And for the imaging, we can do chest X-ray if the patient complain of breathlessness to search for evidence of pleural effusion or pulmonary edema. Next. Okay, so other investigation, this is the specific investigation to rule out secondary causes of nephrotic syndrome. So we can do anti-nuclear antibody test or anti-dsDNA to exclude SLE, serum complement C3 and C4 to exclude SLE and also PSGN, and also anti-streptolysin or test to exclude PSGN. Next. Okay, so the last one, renal biopsy is to determine the morphological variant of nephrotic syndrome. So, however, renal biopsy is not needed prior to the therapy because 80% of children with idiopathic nephrotic syndrome, they have minimal change steroid responsive disease. Nanti. So, my question is, what is the main indication for renal biopsy? Anyone wanted to try? Can we have Faiz?
Oh, sorry, I forgot to open the mic. The indication for renal biopsy is when patient has steroid resistance.
Yeah. Okay. Yes. True. Okay. So, if patient, so the main indication for renal biopsy is actually the steroid-resistant nephrotic syndrome, which defined as failure to achieve remission despite 4 weeks of adequate corticosteroid therapy. And other indication, features that suggest non-minimal change in nephrotic syndrome, such as if patient have persistent hypertension, renal impairment, and or gross hematuria, then we can do renal biopsy. Okay, that's all from.
So okay, so for my part is the management part. So, sorry. Okay, so there's a few terms that we should know. So one of the terms is first is steroid resistant nephrotic syndrome, which is when mentioned by Hani, is defined as when the child is failed to achieve response to initial treatment or 4 weeks treatment with prednisolone of 60 minutes. And steroid dependent nephrotic syndrome is actually 2 or more consecutive relapse occurring during the steroid tapering or within 14 days of cessation steroid. And relapse nephrotic syndrome is defined as urine albumin excretion more than 40 microgram per meter square per hour or urine dipstick 2 plus or more for 3 consecutive days. So we know that for management we have the general management, which in general management is that what we can do is give a normal protein diet is recommended. We prevent salt to the diet, and we give penicillin 5 recommended during the diagnosis and during relapse. And then we should assess the hemodynamic status, give diuretics, but diuretics are not required. And human albumin can be used in symptomatic cases, but the mainstay treatment will always be the corticosteroid therapy. So for corticosteroid therapy, we have two types. Is initial prednisolone. We have two phases, which is the initial prednisolone and alternate day prednisolone. So I would like to ask the audience if anyone would like to try the dose and also for the duration of each initial prednisolone and alternate day prednisolone. And now would like to try.
Can I try?
Okay. Sure.
So for initial prednisolone,
Uh-huh.
60 milligram per
Uh-huh.
meter square per day. Meter square, sorry.
True.
Okay.
For how long?
Okay. For 4 weeks.
Okay.
Okay. And then after that, for alternate day prednisolone, we give 40 milligram for 4 weeks also. And then after that, we try to taper for 4 weeks, and then we can stop the medication.
Yes, true. As mentioned as well, sorry, I forgot to add the tapering. But yes, as mentioned, we give the initial prednisolone 60 milligram for 4 weeks every day, and followed by alternate day prednisolone of 40 milligram per day for 4 weeks duration, and taper off over the 4 weeks and stop. So usually, 80% of the children will achieve remission, and we confirm it by use urine dipstick having nil or no result for 3 consecutive days. And this is a type A error. So the definition of steroid resistant nephrotic syndrome is anyone would like to try what's as I mentioned before, what's the definition of steroid resistant nephrotic syndrome? Just to recap. Because if 80% achieve therapeutic means the 20% more usually are those resistant. So how do you define someone having resistant? Anyone would like to try? Faiz, would you like to tell me the definition?
Yeah, definition.
How do you say the patient is steroid resistant?
Steroid resistant. Sorry, I do not remember the
It's
numbers.
okay. So the steroid resistant, when we see two consecutive relapse means the relapse of the condition during the steroid tapering or within the 14 days of the cessation of the steroid itself. So then if the patient is steroid resistant, then we should proceed with one of it is the renal biopsy. So this is from the latest for edition in the second the modified part, which is this is the table showing you the steps in prescribing the oral prednisolone. So as mentioned, we have the initial phase and also the tapering phase. So this one you guys can go through and look how they do the steps. Okay.
Sorry, come back to this important table because it must be very clear for you. So steroid resistant, it means it will not respond, yes,
Yes.
within this 28 days, 4 weeks.
Right.
If the other one respond, but when we are trying to taper, it means it is steroid dependent.
Oh.
There is some difference between steroid resistance. It is not responding to steroid. We must go ahead for renal biopsy now. Steroid dependent, okay, it means we cannot taper the steroid or the patient, we cannot stop it for a longer time. You must think about that. Frequent relapse, you must know. Okay, it is very important. What other we will say it is chemotherapy. Yes, it is chemo, but we are not set chemotherapy at all at this situation. We just know its name. Its name is immune modulating drugs. What is the name? Immune modulating drugs. I know that it is used for cancer, but if you tell the patient with nephrotic syndrome, I am going to give you chemotherapy or anti-cancerous medication, he will be very panic because we are using this with another regimen and another. Okay, so what is the name? Immune
modulating
drugs. Okay, it is the same, but take care about our just pronunciation of one word with the patient may make his life very terrible. Or it may be think the mother it is a background of malignancy and go to other doctor to ask and she's very worried like that. Okay, good. So please, here is the medicine. There is like a very small hair line between different things. It must be clear to us. Okay, continue.
Okay, thank you, Dr. So, okay, these two pictures showing you the drugs, which is rituximab and also cyclophosphamide. So, anyone would like to guess what category of agents are these? What type of agents are these? Anyone? Volunteer?
So when patient develop steroid toxicity, so we might consider to use cyclophosphamide or rituximab.
Okay. But what do you call this? What do you call this category? Rao?
Steroid.
Yes.
Can I try?
Steroid dependent? I don't know. Okay.
Please try. Anyone?
Steroid sparing therapy.
Yes, true. Yes, steroid sparing therapy. That's what this is the type we call steroid sparing therapy. But it's true what also Rao mentioned that if the patient is steroid dependent of the syndrome, especially with steroid toxicity, we can prescribe this to the patient. So these are the examples. One is the cyclophosphamide and also other type is rituximab. There's a lot more where you can look through the CBGs. This is just an example I would like to share with you. Okay, that's all from me. Pass the mic to Afika.
Yalla, 1 to 2 minutes, Afika, please.
So I would like Hazira to answer the question. So based on the pathophysiology explained previously, what do you think the complication would be? There are three complications. Please
It's
list.
first one is hypovolemia. Second is thrombosis, and also spontaneous bacterial peritonitis.
Okay, correct. So the most common one is the spontaneous bacterial peritonitis. And for so these are the explanations. So for hypovolemia, the treatment is usually we infuse human albumin at stat dose 0.5 to 1.0 gram per kg stat. And usually we should not give furosemide to patient with hypovolemia because it will worsen the hypovolemic states of the patient. And for primary peritonitis, we treat it with parenteral penicillin and generation cephalosporins. And for thrombosis, we treat it with anticoagulation, for example, warfarin, and it also requires further investigation. Okay, I think that's all for the complications.
Uh, Thank you. Now I used it to tell any tree has root and fruit. Yes, our disease is a tree. We must try to ask ourselves what is the root, what is the fruit. Like this case is a very clear one. This is the nephrotic syndrome. I will say, is it relapsing or steroid sensitive or steroid dependent? But its root can be primary or secondary. And if secondary, it will be secondary. So I can say it is secondary nephrotic syndrome, secondary to SLE, secondary HIV, secondary to chemotherapy or malignancy. Okay? So that is the issue. This is the root. What is the fruit? The complication, which you speak about, either sepsis, either thrombosis, or even steroid side effect, which is a Cushing syndrome. That's why you must put a complete diagnosis for the patient, so you will treat everything. Where you are prescribing steroid, you must take care if the patient has cushingoid, how to do. If you need to go to steroid sparing medication like that to decrease the dose. So every point have its own. So please, we try to come to conclusion to be more professional in putting the diagnosis, so it will guide us how to investigate, how to treat, and how to give the patient the best care. And if you said the best care from medical point, it means his life will be looks like normal. At the same time, you will be a professional doctor. You will be accepted from Allah that you are doing your job as optimum. Am I clear?
Yes.
Thank you. See you again. Sorry for time is passing very rapid. I need to send you today in the group who present what, the first group, the second group. If you are going to give you marking, I will establish with the department for that. And the second thing, you revise your case and your OSCE and also drop it, okay, to me. Thank you. It's your rule if you have 1 minute to ask any questions.
Doctor, can I ask one question regarding the, because example, if patient are not responding to steroid, we can also use immune modulating agent, right? But what if we use that one also, but there is no response to it? I mean, even in that treatment, what will we do after that if the patient
Yeah.
cannot respond to immune modulating agent?
Thank you for your good questions. You evolve with me the importance of subspecialty. If all of you consider the importance of subspecialty, it means you will be responsible for a very limited disease, but you are going deep. Even if there is one patient in Malaysia, you must go for it. Okay? For if you obstructed with any patient, you must go for your specialty. But the most important for you is to think about how to be subspecialized, because your country need a lot of subspecialties. Okay. If you are going to start your master soon or whatever postgrad, and thinking how you do rotation or like that in subspecialty, it will be the best for you and for your country. Okay, but here the subspecialty have many ideas for that questions. Okay, sometimes you are using the fluvermal, which is the antihelminthic. You will find it in your protocol also. This is antihelminthic drug, which is given once if your patient has a scaris or like that. But it is immune modulating drugs. You can add it to the steroids. It is very effective, really. But you are going to give it daily for maybe 1.5 years. Okay, you can read about that. There is cyclophosphamide. If no response, there is cyclosporin. If not, you have the new generation of drug which can modulate like anti-immunoglobulins like that. So we have a lot. Even the specialized one can choose for every patient what is the best for him. It is not shameful at certain level to say, I did what I know, I need to consult others. Two, please, rules, use it in your medical field. Don't shy to ask for help. Don't shy to ask for a senior opinion. It's not. Even in MRCP, some of colleagues buzzed very simply because they are natural. The doctor asked him, just you are pricked by a needle with a patient who have hepatitis B. What to do? He said, cleaning like that. So I asked him, how is the percentages of that? He said, I know that I cannot remember. I will revise that in the book. He considered him did the correct thing. He can remember at that moment. And then I asked him, what you are going to prescribe? I said, I must contact my senior rapidly to take decision about what we must give. I am need to give immunoglobulin, IG, like that. So he accepted him because he passed the other, but he said he is dealing natural. Sometimes the knowledge is in your hand, but you can open the book and read. Sometimes this is the best of your knowledge available in the pediatric protocols, and so I need to ask senior one. Ask for help, ask the senior opinion, don't be shy. It will increase your point in front of Allah and in front of the people. You said, no. They will say, I am ignorant, I don't know. No. All of us must continue. In Arabic, they said, al-ilm min al-mahd ila al-lahd. To get new knowledge from mahd, from the first point you cry, you delivered, lahd, the moment you are going to pyramids, you must continue learning. And the Islam said, وَقُلْ رَبِّ زِدْنِي عِلْمًا. And they said, فَوْقَ كُلِّ ذِي عِلْمٍ عَلِيمٍ. Even the one who is very knowledgeable, there is someone has knowledge more than him. No problem at all. The most important, this patient must get the top care through me. Okay? Thank you for that nice question, and I hope I can see some of you a pioneer in some subspecialty within a short time. Maybe you don't know, I am graduated more than 36 years now, or 36, maybe more. 30, 83 until now, it is 37 years. It may be after 10 years, I can find some of you a very pioneer in whatever subspecialty. And it is easy. Just to continue your thinking and your way as you are still a student until you finish your subspecialty. It will take some time, but it is very beneficial for yourself, for the patient, even for the country. We still have a shortage in many subspecialty. Okay, thank you, and see you again, inshallah, soon. If any one of you have any problem my help for that or to need discuss anything, even he can contact me in the private until we are able to see us, inshallah, face to face.
Doctor,
Yes.
if we have any question, can we ask in the group, Doctor?
Hoping if it is limited, if you cannot find it, do you have up to date and our kulliyah is lib? You can go through the library for, if you cannot get answer through the library, you can, of course, you are welcome anytime, but it may take some time to be able to answer, especially if I'm in call. Okay. Assalamu alaikum wa rahmatullah.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Actually.